surgical crike, a couple of ways you can do it. You can do the open surgical method, which is basically scalpel, ET tube, make your hole, introduce the ET tube. That's the old school and probably the most difficult way to do it. Next option would be bougie assisted. You just take a bougie after you make your incision, introduce the bougie past the scalpel. That'll hold your place, and then use that as an introducer for the ET tube. The way that we're going for is dedicated crike kit. You got your rollout kit. You have your actual specific tracheostomy tube. The tracheostomy tube, as you notice, is much shorter, and it has its own dedicated stylet. Okay, it's hard rigid. It's much better than the stylets that are in the endotracheal tube. In the kit, you also have, just like you do for your ET tube, you have a 10 cc syringe to inflate the cuff. So, for training purposes, going to be using an ET tube. Also in the kit is the crike key. This is a key piece of equipment in this kit. This part here that's not sharp is what you use to hold on to and to pull. The covered part is pointy and sharp. So beware of that. We'll get to that here in a second. So first things first, anatomy. You want to go for the cricoid cartilage at the bottom of the Adam's apple, not the notch at the top of the Adam's apple. It's right at the bottom of the Adam's apple, just before you hit the cricoid rings. You can either do a horizontal or a vertical incision first, whichever one you want to do first. That's kind of user preference. On this training dummy in particular, we're going to need to do a horizontal just because of the way that it's made. Personally, I prefer doing a horizontal. Be aware that you need to go ahead and prep all your equipment just like you do for intubation or anything. Once you make the first incision, it's going to become completely bloody mess. Your field of view is going to go to crap, basically. So once you commit to doing the crike, you always keep something in the hole, okay? Pass something over, like I said, with the bougie aided, you would put the scalpel and then you would pass the bougie, okay? This is where the crike key comes into play. So for this one, we're gonna use the crike key. We're gonna find our anatomical location. You can find the large notch at the top of the Adam's apple, follow it down. You're gonna find the soft cricoid cartilage in between here, right before you hit all the cricoid rings. All right, so here's what we're shooting for, okay? Right in this area. So I'm gonna go ahead and make a horizontal incision, about an inch, number 10 blade. Go ahead and keep that. I'm going to take the crike key, insert the pointy end, nice and sharp against the tissue. I can remove the scalpel at that point. I'm going to go ahead and pull traction caudally or towards the head. That's going to help open up. Can you pull down on these? Because a human won't really move as much. So, if need be, you can make an additional incision to increase the size of your hole. Do not take the scalpel and simply waller out the hole. Okay, that's not good for the patient. We don't want to cause any increased trauma. Again, for training purposes, I'm using this 6.0 ET2. You keep this right here. The stylet's fine. We'll end up removing it, yeah. Just like intubation, at that point, you're just using it as a guide. So, again, the crike key is a nice piece of equipment because it's going to help you keep that hole open, keep it patent, and allow you to pull traction and better, have an easier time of inserting and introducing your tube or your tracheostomy tube. So at this point, we'll pull that out. That's in there. It's a simple, because it's a hook, remember that it's a hook, so don't just try and pull it out. Push forward, rotate, and then remove it. So you're not causing a bunch of unnecessary trauma. And then at this point, use tape or whatever means. Right? Yes, use the 10 cc syringe to inflate the cuff and then secure it in place. The kit has its actual own securing strap that's specific to the tracheostomy tube. But again, like with anything, you can use tape or any other securing means.
versus like a traditional?
So with the tracheostomy tube, you're going to just actually put it to the hub. Okay, that's the depth that you're looking for. You will end up seating that right there and then securing it.
So you'll seat it down to where?
Seat it down to the flange, to the neck of the connector, the adapter that goes to the BVM. So you'll actually just seat it all the way until it doesn't go any further. As far as depth, when you're looking for if it's an adult or a pediatric or something like that, yeah. Basically, you're just gonna feed it down. You may even feel some resistance when you hit the branch, and then pull back a little bit. But if you think about it in the grand scheme of things, right? If you're using an ET tube, yeah, you're just shooting for the same size as a tracheostomy tube. So 3 to 4 inches, no more. Pull it back if you need to. As you ventilate, auscultate, look for a good in-tidal, all the other things that you would normally do for your airway for intubating someone, right?
I'm using a field expedient ET tube. Is 6 the appropriate size, or do we not carry it? Would it better to do
6 is what you're shooting for, yes. Okay. Yeah, if you're going to use endotracheal tube, you wanted to use a 6.0. Now, if it's a pediatric or something, obviously you can go smaller. You're probably not going to be able to pass something much larger, maybe a 7, depending on the person's anatomy. If you do the bougie-aided technique, you will need to use a 6 because anything smaller than that actually won't pass over the bougie. You won't be able to use the bougie as an introducer. But if you use the standard open surgical technique, then a 6.0 should also work well.